morning. Thank you very much, Mr. Chairman. Thanks a lot to Sanjay for the very kind invitation. It's a pleasure to be back here. Actually, I was here as a delegate like 10 years ago, and it's an honor to be here as a speaker, faculty, and share my experience with some of the best bioethics surgeons in the world and my few friends. So. This is my hospital, International Medical Clinic, Airport Road, Miami. We almost do everything. Medical Clinic International is the third largest healthcare provider in the world outside the US, and we're part of that group in the Emirates. This is my clinical disclosure. I have no financial disclosures. I do mostly sleeves, followed by revisions and OAGBs. And then gastric bypasses, very little anything else, if any at all. So this is a subject that's been intriguing surgeons for a long time. The debate is never over, still there about should we buttress the staple line or not. And this is typically for the sleeve gastrectomy because this is where this issue is mostly discussed. And when we talk about it, there are three ways. I mean, I'm sure that we have sense when we discuss with other colleagues. There's some evidence-based discussion, and there's some sort of dogmatism always, and sometimes even belief polarization. So what is belief polarization? It's also called attitude polarization and polarization effect. So this is where a disagreement becomes more extreme between two parties considering the same issue and their view of the evidence at that issue. And it can take the form of group polarization, and all of us are aware of that, especially those who are fond of legal series on TV, and where a lot of juridical discussion takes place. And data and studies have proven that the jury members often decided on a punitive damage award that is larger or smaller in quantity from that they would have decided themselves individually as jurors. And that is actually called belief polarization because the personal conviction changes with the group. What is worse than belief polarization is dogmatism. And this is the tendency to put principles as if they were undeniably true without consideration of evidence or opinion of the others. And this is what we sometimes sense. I'm not referring to anybody. When someone says, I believe, I think, we then all lose interest in that because it's not about what I believe, it's about what my data says or the numbers says. But that dogmatism is actually there, and we've experienced this with people in different directions. So dogmatic is the term given to expression of personal opinions very strongly or positively as if they were facts. And the practice of dogmatism entails the expression of belief that the person or the group that you're discussing with some issue are required to believe exactly what you believe. Or even what is worse, that they are not really intelligent enough as you are if they didn't believe what you believe is true. And again, not considering the evidence. I'm going through that because I've sensed that. I went through that in different discussions many times. The thing is, the way we look at evidence is, even when you go to evidence, looking at evidence can be sometimes subjective. And having a fossil and just judging from that print on a rock that evolution is true is not based on anything. I'll give an example of that. A very nice example at the end of my presentation. So instead of that, we should go to the standard level of evidence, and this is something that is agreed upon. And when we talk about level 1, 2, or 3, then everybody who's listening to you or talking to you will know what you are referring to, and that will make the discussion really objective. So what about staple line reinforcement? Well, the two things that are important here are the bleeding and the leak. Those are the two major issues with handling a staple line. So let's talk about bleeding first. This is and of course there's so many studies and always limited them whenever we talk. So I'll get I've chosen a few papers where a large number have been used and credible sources have arrived at conclusion based on data. So this is the data from the NBSA quick data for 2015, and it's talking about patients who underwent sleep gastrectomy. They were stratified to, that was for the year 2015, and to stratified into, the thing is, I cannot see well without the glasses, and this is too small, the glasses, so, yeah, that's what happened when you are not very old and not young, we're just old. So, so as you can see here, the NBSA data for 2015 was implemented here. Patient was classified by staple line treatment alone, oversewing, buttressing, and a combination. And the primary endpoint was the post-op bleeding. The conclusion here was very clear relative to nothing done. The use of oversewing and buttressing decreased the post-op bleeding by up to 30%. And this is data. There's nothing personal here or an aggressive point of view. So that's why surgeons, this paper says that surgeons, encourages surgeons to implement buttressing all the time. This is an even bigger data that was published by the SNBS, a very credible source of information most of the time. I tell you why at the end of the presentation. I show you why at the end of this presentation. And the data here for the program for 2015 and 16, as you can see, about almost 200,000 patients. That's a really big number of sleep gastrectomies were grouped into no reinforcement, oversewing staple line, and a combination of reinforcement and oversewing. And multiple variables, variable analysis was used here to analyze the 30-day outcome. So there was no statistical difference between mortality and overall morbidity or decrease. The bleeding and the operation rate was significantly higher in patients with no staple line reinforcement, which really take into conclusion that the reinforcement is definitely improves the bleeding and the operation rate at the 30-day post-operative period. That was for the linear studies. What about the circular studies? Does it fall under the same category? Yes, it does. And as you can see here, again, this is a big study for buttressing the circular line and Roux-en-Y gastrogenostomy, bypass, gastrogenostomy, and anastomosis on 250 plus patients divided into two groups. One, almost half, had buttressing and the other didn't, and it was analyzed according to the standard analytical, I think it's the tissue test or chi-square test here. So the specific risk of bleeding-related complications were significantly lower in the group in which buttressing was used, and as you can see the numbers, 0% versus 3.1%. That's a very significant outcome between the two. And the conclusion was definitely that buttressing of irregular circular line gastric bypass definitely improves the rates of bleeding and bleeding-related complications. Not only that, so researchers went into checking the effect of the buttressing on the clinical outcome, the clinical features, and particularly post-operative nausea and vomiting in the first few hours, day following surgery. And this is a study that included 100 patients with sleep gastrectomy, and there are two groups. The endpoint was post-operative nausea and vomiting after sleep gastrectomy, and there were two groups. The group with the staple line reinforcement and the group with the oversewing. And you know, I mean, over suturing. And you know that two, and it's not our topic today, I have another presentation about that, but there are two ways of oversewing. There's the invagination and going through and through. And this study is implementing the most popular one, probably most surgeons do, invagination. versus the staple line reinforcement. And the data was clear. There was a significantly different, higher rate of post-operative nausea and vomiting in the invagination suturing group compared to the reinforcement group. And of course that was reflected on not only on nausea and vomiting, but it was also reflected on delaying the oral intake by patients in the first few post-operative hours, and having increasing the need to keep them for a longer time. And with everybody now going to LIBSS and discharging patients on the same day, that can probably be detrimental to your plans in that direction. So what about leak? This thing has not been touched really by our papers until like 6-7 years ago. And this is one of the first papers that studied almost 2,000 patients with the sleeve gastrectomy, the correlation between post-operative leakage and some preoperative and post-operative variables, as you can see here. That's a large number of things: age, gender, height, blah 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 to the end, and post-operative, which is distance from the pylorus, operative time, experience of the surgeons, and the surgical material used were analyzed. And the data here clearly showed that there's a lower incidence of leakage, a p-value of 0.05, which is significant compared to the patients who did not have buttressing. So the conclusion was the proximal staple line reinforcement does maybe lower the risk of leak. And that was followed by a very famous study, which was carried out by Professor Gani and co. And he actually compared the five modalities of reinforcement that we all know, and it was a meta-analysis of sleep leak on patients done between 2012 and 2016. And those are the variables there, and independent Fisher exact test was used to compare between the various modalities and the outcome compared to leak. And the conclusion was very clear: there was significantly lower rate of leak using staple line reinforcement as compared to the oversealing with the use of sealants or nothing at all. So that, there are quite a few other papers that go in line. There's definitely an increase in evidence now that staple line reinforcement does decrease the rate of leak, not only bleeding. But I'm sure that a lot of you, if not all, said, why did he skip this? This is arguably, or probably, the biggest study about the variables affecting sleeve gastrectomy, and it was published by the SMBS knowledge. And if you look at the numbers, they are horrifying. Anything that comes out of such study should be respected, right? Well, as I show you that, I go to that slide when you take a stone with a print and you say that's a solution. Not necessarily. Look at the numbers. This is a study that included a total of almost 200,000 sleeve operations that was performed by 1,654 surgeons at 720 centers. Can you believe it? A huge amount of data. And 80% of the surgeons did use reinforcement, and the result was that these staple line reinforcement cases were associated with a higher incidence of leak. That was the first paper that said there was a higher leak. All the other papers say it didn't help reducing leak, but this paper with this huge number from the SME said that it actually increased leak. And of course, the other important thing that they talked about was the bougie size, and they found that the bougie size of less than 38 increased the incidence of leak. And so the staple line reinforcement conclusion is it increases leak. Remember that slide? Well, not necessarily. The large data proves a point of discussion. That is probably, I would say, it's some sort of a dogmatism rather than polarization or evidence. This why? Because we go back to the principles. What is the thing that we depend on most when you want to judge data coming out of a study is nullification of variables, right? So to make sure that the stable line enforcement was the reason, or to make sure that 2 minutes, the stable, one X is the reason for the outcome. You have to unify A, B, C, D, E, F, G action. So everything is right apart from Y. So Y is responsible for the outcome. But look at this data. 1,654 surgeons coming from 720 centers. How could you really unify their practice? What sort of, they didn't really mention what sort of stable line enforcement was mentioned. They didn't really have the same pre-op, post-op follow-up. What are the parameters they use to judge their patients, prepare their patients? So many things. I mean, the higher the number of surgeons and the higher the number of centers, the higher the number of variables. Unless you have a way of showing us really that all the variables were eliminated, and those numbers, the only thing was that the league was higher, then I would say yes. But even the stable line reinforcement here was not unified. We don't know what was used, how it was used. Well, anyway, there are people whose part is reinforcement party not, and I don't want to waste your time. So this study has been criticized a lot, and I don't think a lot of people are referring to it anymore. So eventually, I've shown you the evidence, and the evidence says that stable line reinforcement does decrease the bleeding rate, does decrease bleeding complications, does increase nausea and vomiting, and does increase leaking. Thank you very much.